Hello everyone, we are from small group discussion B8, and in this occasion we would like to present our student project where we answer some questions, then we find a journal, then we critically appraise that journal based on the scenario that has been given to us on the study guide. These are the members of our group.
Okay, next, I'm going to tell about the risk, benefit, patient preference, and comparison with alternatives. And I'm going to tell about the background. The first one is risk benefit project assessment. Diabetes mellitus or showed protective chronic metabolic disorder marked by hyperglycemia, affecting over 537 million adults worldwide in 2021, and projected to reach 700 approximate NNT 85 million by 245. One major renal or cardiovascular event may be prevented. Nephropathy until 6 remains a major cause of chronic kidney disease or no evidence of harm and no HR under renal disease. Or second one is patient preference progressing from microalbuminuria to declining non-pharmacologic filtration rate or GFR. Key risk factors include fear, weakness, or malnutrition, regional economic difference, and food accessibility affect adherence. Cultural the importance of early guidance using local protein sources is central to DN care, but often controversial. Tofu, beyond caloric and carbohydrate ideally protein modulation has gained attention. Low protein diets last one LPD, is comparison with alternative. LPD complements 0.6 until 0.8 grams per kilo per day. Are proposed to reduce glomerular or ARB as first-line treatment and show renal decline. Yet some guidelines still favor normal protein intake of 1.0 until 1.2 grams cardiovascular benefit to prevent malnutrition and sarcopenia. Measure salt restriction, particularly in active middle-aged adult. This conflict remains in the case of a 40-year-old male teachers with DN who received different dietary and recommendations. Evidence from meta-analysis suggests LPD may slow GFR decline and reduce protective effect, although outcomes vary with CKD stage, adherence, and study quality. In this uncertainties underscore NES, the approximate for an evidence-based medicine or EBM one major renal or cardiovascular event questions may be prevented appraisal to guide personalized patient decisions in the management. Now for the problem statement. The following key problems arise in addressing the therapeutic dilemma in this scenario. The first one is, what type of question is posed by the above scenario? Second, how to build up a clinical research using PICO. Third, how to formulate a clinical research question from the scenario above. Fourth, how to search for the best evidence journal to answer the clinical research question. Fifth, how to apply critical appraisal to the journal. Sixth, how to critically appraise the evidence or journal found from this search or find out how good it is and what it means. Seventh, how to apply the evidence by integrating the result with clinical expertise and patient values. 8, and last one is how to apply value-based medicine and critical appraisal to the journal. Now for the objective. The objectives are to resolve the identified problems through number 1, identifying the type of question in this scenario. Number 2, building a clinical research question using the PICO framework. Third, formulating a clinical research question directly from the scenario. Fourth, searching and selecting the best evidence from the journals to answer the clinical research question. Fifth, applying critical appraisal to evaluate the journal's methodology. Sixth, critically appraising the evidence or journal to determine its quality and implications. Seventh, applying the evidence by integrating it with clinical expertise and patient value. And last one is applying value-based medicine principles alongside critical appraisal to the journal. And last one is benefit. This approach provides significant advantage. The first one is to enhance patient outcome by clarifying evidence on dietary interventions. potentially delaying renal progression while addressing nutritional concern, thus improving adherence and quality of life. And second, supports clinicians and healthcare system in delivering cost-effective personalized care through EBM, reducing long-term complications and resource utilizations in managing diabetic nephropathy.
Okay, this is the case, and these are the questions that we have to answer, and the answers of these questions each will be presented by my friends. Thank you.
Greetings, my name is Herberth, and with last three-digit numbers of 169. So the type of questions of our case, diabetic nephropathy is one of the common long-term complications of diabetes mellitus associated with chronic kidney disease. In this scenario, the patient receives two different dietary recommendations. One physicians recommend a low-protein diet to slow the progression of declining renal functions, while another physician suggests a normal protein diet with caloric restrictions to maintain nutritional status. The patient then seeks evidence to determine which dietary approach is more effective in preventing further deterioration of kidney functions. The shift from general knowledge about diabetic nephropathy to a specific intervention type questions involving a low protein diet indicates that this scenario relates to a foreground clinical questions.
I'm Helena with my last three-digit student ID number is 141. So according to the scenario given, the population that will be used as a sample were type 2 diabetes mellitus patients with chronic kidney disease. And for the intervention is low diet protein, whereas whereas it will be compared to another comparison group that consists of patients who consume higher levels of protein or without limitation, and the outcome that will be evaluated is the decrease of renal function progressivity.
Greetings, I'm Gusti, Agung, Krisania, Mahaputri. With the last three digits of my student number, R143 will continue. So based on the established PICO framework above, the following clinical research question was formulated, which is in patient with type 2 diabetes mellitus and chronic kidney disease, does dietary protein restriction or DPI confer greater benefit than higher protein intake or unrestricted protein consumption in attenuating the progression of renal function decline? Maybe that's all from me. Thank you.
Okay. Let me to introduce myself. My name is Partha. Last three digit of my number is 00. I will explain about literature search and study selection. In this project, we conduct a literature search using PubMed, advanced search based on PICO framework, focusing on patients with type 2 diabetes and chronic kidney disease, particularly diabetic nephropathy. We use keyword related to low protein diet and renal function and limited the search to recent high-quality observational studies, clinical trials, and cohort studies. From this process, we selected one primary article for critical appraisal, a 2025 retrospective cohort study by Liu et al., which followed 820 patients over 10 years and evaluate the long-term effect of dietary protein intake on CKD progression in type 2 diabetes mellitus. This study aligned well with our PICO and serve as our main evidence source. Okay, that's all for me. Next, we'll explain by my parents. Thank you.
Okay, my name is Nengah Pedoman. With my last three-digit number is 051. So I will still continue the presentation about the literature search and study selection. So in this data, we can compare that between patients with low protein intake or DPI less than 0.8 gram per kilogram per day, and those with high protein intake or DPI more than 1 gram per kilogram per day. So in this comparison, we can conclude that the patient with protein restriction exhibit a significant reduction in the risk of kidney disease progression. So this data tell us about the both analysis, univariate and multivariate. So the low protein diet group show a risk reduction up to 56% after adjustment for various confounding factors. And the consistency of the result was also observed after applying PSM or propensity score matching, which aim to reduce selection bias. And the additional to renal outcomes, The study also tells us about the reduction of mortality risk up to 63% before matching and continue to demonstrate significant benefits after adjustment for all of the confounding factors after PSM. So it's approximate 47% reduction in mortality risk compared to the patient with usual protein intake, which is that's more than 1 gram per kilogram per day. So these findings, the conclusion is long-term protein restriction is not only associated with slower progression of kidney disease, but also correlate with overall improved clinical outcomes. And these journals support the low protein diet, or DPI, diet protein intake approach as one of the non-pharmacological strategies in the management of diabetic kidney disease, particularly in the context of preventing the progression of renal function decline. So that's all from me. Will be continued with my friend. Thank you.
Thank you. My name is Gede Pramaditya Wahyu Saputra, and the last 3 digits of my pseudo numbers are 045. In this occasion, I would like to present the detailed answers of each questions from section A, validity, from a critical appraisal for cohort studies. The first question is, did the study address a clearly focused issue? Yes, the study specifically focused on the beneficial effect of low protein diet intake with DPI serum urea creatinine less than or equal to 1 gram per kilogram per day in preventing the progressions of declining kidney function. This was assessed by measuring the time to dialysis initiation, kidney transplantation, and serum creatinine levels in patients with diabetes mellitus and chronic kidney failure. The study clearly states who the population is, what intervention was performed, what comparison group was used, and what outcome was intended to be measured. The second question is, was the cohort recruited in an acceptable way? Yes, the study explicitly discusses how the sample was recruited. To prevent bias and increase the generalizability to the sample to the general population, the study used 2 data sources. The first data sources was 865 patients already diagnosed with type 2 diabetes mellitus and chronic kidney disease according to the American Diabetes Association and KDIGO guidelines from 9 hospitals in China. The second data source came from a National Health and Nutrition Examination Survey, which was conducted by combining interviews with physical examinations. Both samples passed through a strict inclusion and exclusion criteria. The third question is, was the exposure accurately measured to minimize bias? Yes, the study used an objective exposure measurements. An objective method was used, namely the DPI serum urea creatinine formula based on the blood lab results, which are urea and creatinine, and the authors stated that this formula has been validated against the gold standard method, which is the Maroni method, so its measurement is considered accurate and consistent. Question number 4, was the outcome accurately measured to minimize bias? Can't tell. One of the outcomes measured in this study was not explicitly described in terms of its criteria, thus becoming non-objective. Although the renal outcomes such as time to dialysis initiation, time to first transplant, doubling of creatinine, or 50% decline in eGFR are objective, the study did not explicitly detail the operational definition of cardiovascular and cerebrovascular disease outcomes. Without knowing the diagnostic cause or ICD or a specific list of events, it is difficult to ensure whether the cardiovascular and cerebrovascular events were measured accurately and consistently. The question number 5, have the authors identified all important confounding factors? Have they taken count of the confounding factors in design and or analysis? The answer is yes to both questions. The study shows a strong commitment to addressing the selection bias inherent inherent in retrospective cohort studies through the use of two main statistical methods. First, the study applied propensity score matching or PSM to equalize a wide range of baseline characteristics such as age, sex, and comorbidities among the groups. PSM effectively mimics the process of randomization in a RCT, thereby minimizing initial differences between two groups. Second, the final results, or the hazard ratio, was further adjusted using multivariate Cox regression for clinically important residual variables. These combinations of PSM and multivariate regressions is a robust methodological approach to isolate the pure effect of protein intake from the influence of other confounding factors. The last question is, was the follow-up of the subjects complete enough? Was the follow-up of subjects long enough? The answer is yes to both questions. The assessment of the adequacy of the follow-up time shows that the study duration was sufficient to observe the chronic outcomes under investigation, namely the progressions of chronic kidney disease and cardiovascular and cerebrovascular disease. The study included a retrospective observations of up to 10 years. Clinically, terminal renal outcomes like dialysis or ESRD require a long period of time to manifest. Furthermore, the reported median follow-up time is also sufficient to capture significant clinical events, thereby increasing the temporal validity to the study's result. That's all from me. Thank you.
Okay, thank you for the time. My name is Yuda with 3 last digit of student number 069. In this question, I would like to explain the section B. What are the results? The first question is, what are the results of this study? The answer is yes. The study indicates that the low protein intake, less than 0.8 gram per kilogram per day, is linked to substantially lower risk of major clinical events. In the Guangdong cohort, low intake reduced risk by 44 until 63%, and in NHA and ES, it's lower all-cause mortality by 47 until 63%. Hazard ratios less than 1 consistently show the protective association. The second question is, how precise are the results? The answer is yes. The results are precise because all analyses before and after PSM report 95 confidence intervals that are narrow and do not cross 1, indicating the stable hazard ratio estimates with minimal uncertainty across both datasets. The third question is, do you believe the results? The answer is yes. The findings are credible because the effects are large, consistent, and show clear dose-response pattern. Similar results in two distinct populations, Chinese outpatients and the US general population, make bias or chance unlikely. The association is also biologically plausible, as lower protein intake may reduce hyperfiltration and metabolic stress. Although observational, the study's strong analytical methods, multivariate Cox, PSM, time-series analysis, strengthen the reliability of the results. And for the section C, will the results help locally? The first question, can the results be applied to the local population? The answer is yes. The findings are applicable to the local population because the mechanism by which protein restriction slows CKD progression is universal. The cohort design appropriately evaluates long-term effects of protein intake on outcomes. Although local dietary patterns and healthcare access may differ, the results remain relevant with proper contextual adaptation, especially monitoring for malnutrition risk when implementing a low-protein diet. The second question is, do the results of this study fit with other available evidence? The answer is yes. The results align with existing evidence that the low-protein diet can slow CKD progression and reduce proteinuria. Prior studies and meta-analysis consistently support moderate protein restriction, so the findings from both datasets are in line with the broader literature on CKD management. The last question is, what are the implications of this study for practice? The answer is yes. The study suggests that restricting protein intake less than 1 gram per kilogram per day, especially less than 0.8 gram per kilogram per day for CKD stage 2 and 4, may offer nephroprotective benefits, provided nutritional status is closely monitored. While one observational study alone cannot change clinical policy, the consistent findings from two large cohorts reinforce current recommendation and indicate the DPI-SUCR may be useful as tool for monitoring protein intake in routine practice. Okay, that's all from me. Thank you.
My name is Gusti Kirana, and the last three digits of my student ID number are 212. So I'll be continuing the presentation about the critical price of the evidence or journal that we find for our student project. So in a critical appraisal of a journal, there are 3 sections. The first one is about the result, are the result valid, or about the validity. And then the section B, or the second, is what are the result. And section C is will the result help locally. So in section A, for the first question is did the study address a clearly focused issue? And the answer is yes. Was the cohort recruited in an acceptable way? It's also yes. And was the exposure accurately measured to minimize bias? It's also yes. And then was the outcome accurately measured to minimize bias? Can't tell. And then for the fifth question, section A, have the authors identified all important confounding factors? Yes. Have they taken account of the confounding factors in the design and or analysis? It's yes. And then was the follow-up subjects complete enough? Also yes. And was the follow-up subjects long enough? Also yes. We will move on to the section B, which is what are the results. What are the results of the study? This is also yes. And then how precise are the results is also yes. Do you believe the result is also yes. And then we will move into the section C, will the result help locally? Can the result be applied to the local population? It's yes. And then do the result of the study fit with other available evidence? It's also yes. And what are the implications of the study for practice? And it's also yes. That's all from me. It will be continued by my friend. Thank you.
Okay, so on behalf of G Mahapraja Divasta with 3 last digit number of student ID number is 028. I'm going to tell about the applicability of study to Indonesian patient T2DM plus CKD. First, population fit. The study population, middle older adults, CKD stage 1 until 4, align closely with Indonesian T2DM CKD demographics, where DKD or CKD prevalence continues to rise. Second, protein intake context. Average Indonesian protein intake are 45 grams per day is below recommended level, meaning many patients begin with a lower baseline than Western or Chinese cohorts, potentially modifying the benefit of further restriction. Third, therapeutic difference. Use of RAS inhibitors, SGLT2I, MRAS, and GLP-1RA was uniform in the study but remains variable in Indonesia due to cost and accessibility. Thus, LPD is often implemented within heterogeneous pharmacologist support. Fourth, appropriate use of LPD. LPD, DPI, 1.0 gram per kilo per day is suitable for patients with adequate nutritional status and proper monitoring, but should be avoided in those with malnutrition or risk of PEW unless under close supervisions. Okay, next I'm going to tell about the risk-benefit, patient preference, and comparison with alternative. The first one is risk-benefit assessment. LPD showed protective effect of HR 0.37 in China, 0.50 in NHA, NES, approximate NNT 5 until 6, meaning one major renal or cardiovascular event may be prevented per 5 until 6 patients adhering to LPD. No evidence of harm, no HR under 1. Second one is patient preference and barriers. Indonesian patients generally welcome non-pharmacological options but may fear weakness or malnutrition. Regional economic difference and food accessibility affect adherence. Cultural dietary guidance using local protein sources, example, tofu, tempeh, fish, is essential, ideally supported by a dietitian. Last one is comparison with alternative. LPD complements, not replaces established therapies. ACEI or ARB as first-line treatment, SGLT2 inhibitors, GLP-1RA, and finerenone for cardiovascular benefit. Lifestyle measure, salt restriction, weight control, improve protein quality, remain core strategies. Maybe that's it.
Greetings, doctor. My name is Prasavita Jayawardana with my last 3-digit ID number 193, and today I will apply value-based medicine to the journal. So, this study presents a compelling case for value-based medicine in treating type 2 diabetes and chronic kidney disease. It proposed a best-buy intervention that is high in efficacy but low in resource use. First, clinically, long-term diet protein restriction is proven to delay critical endpoints like dialysis and transplant, especially in stage 3 and 4 chronic kidney disease. Second, operationally, it solves the monitoring bottleneck by using the serum urea creatinine ratio. This allows us to use routine lab data at zero added cost, replacing cumbersome 24-hour urine collections. Finally, strategically, this fulfills the healthcare triple aim. It improves outcomes, lower the financial toxicity of kidney failure, and enhance the patient experience through non-invasive care. It marks a vital shift from reactive management to proactive disease preservation. Maybe that's all. Thank you.
Thank you, doctor, for the opportunity that given to me. Firstly, let me introduce myself. My name is Komang Chandra with last digit number is 091. So in this section, I will explain about the critical appraisal to the journal. So the objective is to evaluate the effect on lower protein diet on type 2 diabetes with CKD. The design is two cohorts, validated protein intake measurements. The strength is clear research question, control confounder, and 10-year follow-up. The key finding is low protein intake, reduced CKD progression and mortality. The limitation is some outcome poorly defined and residual confounding. The implication is protein restriction may protect kidney function needs monitoring. Next, I will explain about the conclusion. So the question type is therapy question about the whether protein resistance slow CKD progression in diabetic patients. The pickle construction is P type 2 diabetes mellitus plus CKD. I is a low protein diet. C is normal intake. O is CKD progression and mortality. The clinical question: does long-term low protein intake slow CKD progression in type 2 diabetes mellitus with CKD? The evidence search is used databases with keywords low protein diet, CKD, diabetic nephropathy, applying filters to clinical studies. Critical appraisal step is first check validity, results, and applicability using tools like JSP. The quality assessment is study so strong method, but had some outcome definition and observational limitation. The seven is applying evidence that integrate result with the clinical practice and patient preferences while monitoring nutrition. And the last one is value-based medicine that tailor Robert diet recommendation to patient context to support patient-centered decision. That's all from me. Thank you.